Recent advances in assisted reproductive technology have led to a significant increase in frozen embryo transfer utilization, prompting important questions about associated ectopic pregnancy risks compared to fresh embryo transfers. This comprehensive analysis examines current evidence regarding ectopic pregnancy incidence, causative factors, and the comparative risks between natural or modified cycles versus hormone replacement therapy protocols in frozen embryo transfer procedures. Comparative studies show that frozen embryo transfer cycles are associated with significantly lower ectopic pregnancy rates compared to fresh embryo transfer cycles. The protective effect of frozen embryo transfer appears to be mediated primarily through the absence of supraphysiological hormonal stimulation that characterizes fresh IVF cycles. During controlled ovarian stimulation, prematurely enlarged ovarian follicles can disrupt normal tubal function and increase the risk of ectopic pregnancy. Blastocyst stage frozen embryo transfer demonstrates superior outcomes compared to cleavage stage transfer in terms of ectopic pregnancy prevention. Studies consistently show that frozen blastocyst transfer carries the lowest ectopic pregnancy risk, at approximately 0.8% compared to 1.1% for frozen cleavage stage transfer. This success is attributed to the shorter time from implantation to successful intrauterine establishment, reducing the opportunity for retrograde migration. Natural cycles demonstrate ectopic pregnancy rates of approximately 0.47%, maintaining physiological hormone profiles that support optimal endometrial development and implantation window timing. In contrast, HRT cycles show ectopic pregnancy rates of 0.35%, with increased uterine receptivity due to exogenous hormone supplementation. Recent randomized controlled trials suggest that natural cycle approaches may provide superior live birth rates and reduced pregnancy complications compared to HRT protocols. Tubal factor infertility remains the most significant risk factor, with patients having substantial higher ectopic pregnancy rates regardless of transfer type. Previous ectopic pregnancy increases subsequent risk, with recurrence rates approaching 10–15% in this population. Advanced maternal age also shows conflicting evidence, with younger patients possibly having increased sensitivity to hormonal stimulation. Endometrial thickness demonstrates an inverse relationship with ectopic pregnancy risk, with patients showing thickness less than 8 mm experiencing significantly increased risk. The number of embryos transferred also correlates positively with ectopic pregnancy risk, with multiple embryo transfers showing higher risk than single transfers. Pathophysiological mechanisms include altered uterine contractility patterns and suboptimal endometrial receptivity. Patients at elevated ectopic pregnancy risk following frozen embryo transfer include those with documented tubal pathology or previous tubal surgery, history of pelvic inflammatory disease, previous ectopic pregnancy, thin endometrium, and multiple embryo transfer planned. These factors significantly increase the risk of recurrence in subsequent treatment cycles. Blastocyst transfer should be prioritized when possible, particularly in high-risk patients, given the approximately 40% reduction in ectopic pregnancy risk compared to cleavage stage transfer. Single embryo transfer reduces ectopic pregnancy risk and should be standard practice when high risk is identified. Natural cycle preparation appears optimal for ovulatory patients, providing equivalent ectopic pregnancy rates to HRT while offering superior overall pregnancy outcomes. Recent meta-analyses consistently support the protective effect of frozen embryo transfer against ectopic pregnancy. Emerging research into endometrial receptivity analysis and personalized embryo transfer timing may further optimize outcomes and reduce ectopic pregnancy risk. Advances in embryo culture conditions and selection criteria continue to improve the safety profile of assisted reproductive technologies. Based on current evidence, frozen embryo transfer significantly reduces ectopic pregnancy risk compared to fresh transfer. Blastocyst stage frozen embryo transfer provides optimal protection, with rates as low as 0.8% in appropriately selected patients. Natural or modified natural cycle preparation protocols offer equivalent ectopic pregnancy rates to HRT cycle while preventing ovarian hyperstimulation. Single embryo transfer should remain standard practice to minimize both ectopic pregnancy risk and multiple gestation occurrence.